So good morning, and thank you for the invitation. And I'm following up the presentation of Professor Ferrari. I'm Massimo Dominici. I'm working here in Modena, and Professor Fabri asked me to provide some insights regarding the use of stem cells in the setting of chronic diseases. I'm an hematologist and oncologist, so I will try to touch base on generally what is going on in the field, and try to then focus on what we are more doing in the context of tissue regeneration. So what stem cells? I'm going to go briefly through this setting because this has been said previously. Essentially, stem cells are cells which are incapable to do anything, essentially. So, which is a bit disappointing, as said, but their peculiarity is that they are capable to proliferate. And under specific circumstances, they are actually capable to become something. So it's a cells that is ongoing phenotype, which is changing during their step that is called differentiation. What's this differentiation, and why it's important we stress this concept? Because differentiation is a way in which the cells are becoming something which is useful for us, for our day-by-day homeostasis, which is taking place through the milieu of chemicals secreted by other cells, neighbor cells, by physical contact of these cells, and also by molecules which are embedded into the microenvironment where the stem cells actually are living. There are different types of stem cells with different potentials. Moving from the totipotent stem cells to the pluripotent stem cells to multipotent stem cells to then oligopotent stem cells. And this is somehow following up our development, which is actually starting from the zygote to the blastocyst and then to the more differentiated tissue. We will focus mostly on multipotent stem cells, as you understood in the setting of cardiology has been already implemented in the clinical setting. These are, let's say, lineage-restricted multipotent cells. In particular, they have been used in the setting of what is so-called regenerative medicine. These are NIH definition, which is essentially dealing with the development of approach where we can repair, replace, or enhance some missed biological function that might take place after congenital abnormalities, injuries, and in aging. That's certainly one of the future of this field. Regenerative medicine is a very complex field of research. And because we are not only dealing with cells, but we are dealing with biomaterials, with engineered design, we are dealing with biomolecules, and we are dealing also by functional assessment of the regenerated tissue. As you understood in the field of cardiology, you understood how it's difficult to handle the data and the outcome of this study. Well, one of the reasons, because maybe we are limited in the way in which we measure the engraftment of the cells and the potential of the cells after transplantation. So there's a lot of study regarding that aspect as well. So we are working mostly on stem cells, and which type of cells I'm going to talk about is we're talking about mesenchymal stem cells, which has also been mentioned previously. These are, all those stem cells which are limited in their potential, but still very, very useful for some specific application. And next to MSCs, I'm using this acronym for now. There are other stem cells which has been in the past used. One is, of course, the hematopoietic stem cells, which is capable to generate all the blood cells. MSCs are coming, in this case, from a murine bone histology specimen, and certainly can generate, as you see here, is a cartoon showing that these cells are actually capable to generate adipose tissue, osteoblast, and they are around the vessels. So these cells has been also defined as perivascular or pericytes cells, pericytic cells. So if you look back in the history of regenerative medicine, the very first example of that is coming from the hematology field, from Professor Thomas, which did the first bone marrow transplantation to regenerate a damaged bone marrow. And this was the, let's say, the pioneeristic work which generated the idea of using bone marrow transplantation in the setting of leukemia and of solid tumor. You do lethal irradiation or chemotherapy, you abrogate the bad guys, and then you inject the good guys, which are then repopulating the bone for regenerative purposes. But another cell type, which is also very interesting, is coming from bone marrow, is defined as mesenchymal stem cells. We are actually working with this cell type since now quite a while, and we can isolate these cells from different type of tissue, certainly from bone marrow aspirates, but also from adipose tissue, from from cord, like Wharton jelly, from amniotic fluid, and several other tissue which has been also published. So let's get a bit technical. So how these cells look like. So this is just cells taken out from bone marrow, like single cells, small cells. But if you let them go in plastic, they appear like spindle-shaped fibroblastic cells. And if you measure the amount of cells you are capable to pick up just after the tissue harvest, you realize that these cells are very rare in nature, because they are very rare in our body. And this is the naive frequency of MSC's precursors, defined as a clonogenic CFUF. You see the number of them for each ml of aspirate tissue is very little. It's moving from 100 to about 10,000 into the lipoaspirate. And it's even lower if you consider other tissue type. So how about use this population up front without doing any type of manipulation? You certainly pick up the fact that we might be limiting in having an effect, because this is a rare population. So this is what is going on in the last, let's say, 10 years. A lot of technical improvement pushed this field into the need of having an expansion in ex vivo or in vitro. And so we use these bioreactors. These are big flasks, which are capable to amplify the cells up to billions for therapeutical purposes. And if you amplify the cells, you see you purify this population, which is very well defined by markers. I'm not going to annoy you with the technical details, but we certainly know better what these cells are, what they look are, which is their look, and what they are actually capable to do. We are also realizing that during the culture, some events are taking place, the cells are proliferating, but at the same time, the cells are getting to an aging phase, so they senesce, so they become senescent. So how about use these cells for therapeutical purpose rather than these pizza-like cells for therapeutical purposes? Can you imagine this cell infused into an artery or into a vein rather than this cell type? You can just guess what's going on after the injection of the cell type. So it's important to understand that the culture is necessary. It's important to understand the amplification ex vivo may generate artifacts and maybe also detrimental for specific clinical application. In the years, we have been trying to characterize these cells, so we know exactly what these cells are doing in vitro, so we can characterize them by markers, and we can tell these cells to become fat cells, bone cells, or cartilage by cocktails of drugs and growth factors. We also have been implementing a global task force on how we can define these cell types. This is dealing with adipose-derived MSCs, so we can characterize them more by immunophenotypical analysis, by proliferation, by their proliferation, using those assays. It's very important to characterize these cells. And one of the limits, as Professor Ferrari was outlining, is the better definition of the cells before the implantation. So we felt the need to generate standards in characterizing these cell types. So having said what are the cells, how we can handle them ex vivo, let me introduce you the concept of how these cells are actually working. So this is just a simple example. So we have damage here. So the MSCs as stem cell type, they migrate into the damage, they generate bricks, so they repair this wall. But at the same time, these cells, in the last, let's say, 5–10 years, has been also called as having an action of humoral and stromal function. These cells are going to the damage, they're actually producing something, and they are actually capable to rescue resident stem cells of the wall so that these resident stem cells can work together with the transplanted exogenous cells for tissue repairment. So this was an hypothesis we generated in 2008, and then in these last 5 years, a lot of study came up in publication. This is a very recent publication last week from a group in the US, where you see these cells are actually coming from the tissue, they can actually be inactivated, and look here, there is no the word differentiation, there is a word activation and production, secretion. So these cells are actually secreting, anti-apoptotic function, pro-angiogenic, mitogenic, and lots of cytokines. These are actually playing a trophic effect or immunomodulatory effect or anti-microbic effect. So we are shifting from a differentiation potential of the stem cells into a more supporting function. Having said all this, which are the preclinical and clinical applications we as a group and several others in the world has been implementing in the field of stem cell for clinical application? You see most neurological disorders, but also bone injuries and bone marrow transplantation, spinal cord, lung injuries, and of course myocardial infarction. And also been focusing on cancer because I'm an oncologist and hematologist. So if you look at the geographical distribution of clinical trials based on MSCs globally, this is data that I was capable to find into the clinicaltrials.gov. And if you compare the numbers versus 2012, you see that these numbers increase of 26% globally. So you see the numbers, the red regions are the ones which are more intensively working on these trials. There are 71 in US and 84 in Europe, but these are all the ones which are registered. So there is really a clustering of trials which is going on in the world, suggesting the need of high technology to get into the clinical phase. And if you look in Europe, you see the number of, this is a report coming from Home of the Lord, a UK report on regenerative medicine here. And essentially what is clear that in Europe there are a lot of trials going on. There are trials also going on in Italy on phase 1, phase 2, and very rarely you see the numbers on phase 3, suggesting that it's a field that is constantly growing. As said, medicine in science is science, stem cells are science, and stem cells are medicine. So if we want to get to the good result, we need to follow a path. This is the same path that we are following for the drug development. So phase 1, phase 2, and phase 3. So if you look at the number of trials, the percentage of trials using stem cells, which are in the different phase, you see here that there are, in 2013, this is so very recent data I wanted to share with you this morning. So phase 1, phase 2, and again, you see the phase 3, how this is moving, is quite limited if you compare to the other, suggesting that we are still addressing the safety of the cells, we are still addressing the early efficacy aspect, and then we are moving to the phase 3. Which type of application? Well, I think this is a Langenhardt meeting. So you see here that the majority of the activities in the cardiovascular, and there's a lot of work in the neurology, and of course there's something between oncology in here and some other application. If you look at which type of cells are used, well, I would say that most of these cases are allogeneic versus the autologous use. This is coming from the FDA and the EMA registry of application that has been asked in the last 10 years. So it's quite updated list. I'm going to present you briefly our work on bone and cartilage, and then moving into the oncology. Which type of cells are currently using in Modena? Well, you use bone marrow MSCs, but you also use adipose MSCs. For bone marrow MSCs, we're actually implementing a preclinical study, then are now into the clinical setting of bone regeneration. So I was just showing you briefly the fact that we can actually take the bone marrow MSCs, amplify them, and induce them into something. This something, in this case, is bone, is matrix-producing cells, is calcium mineralizing producing cells. We can measure the amount of calcium in vitro by a staining defined fossa. We can quantify this calcium by imaging, and we can say that if you use osteogenic media, you can increase of more than 20-fold the mineralization of these cells. And if you then combine this potential with the biomaterials capable to carry the cells into the human body and to then facilitate their differentiation, in this case it's a calcium phosphate granules, you see that the cells are actually colonizing the scaffold very nicely, generating a sort of pictures, but these are blue cells which are colonizing the scaffold. And if you transplant this scaffold with the cells into a not-skid mouse model, which is an immunodepressed model, which is capable to take human cells, you see that we can actually generate human bone into a murine living beings using the scaffold, which is here. And then here you see the stem cells, which are actually capable to generate our osteoblasts and osteocytes and host the marrow. So starting from this data, we generated a European consortium called Reborn, which is sponsored by the European community, which has the purpose to regenerate broken bones. Their strategy is as follows. So we take bone marrow biopsy, we isolate these cells into what is being called cell factory or cGMP facility. We amplify them in vitro, and we combine them into scaffold to then be implanted into human beings. This is really done in those days. So the cGMP facility is amplifying the cells, and you take a Ferrari and you take these cells into the operatory room, and the orthopedic surgeon are combining the stem cells with the biomaterials to be then transplanted. So our work, I'm not an orthopedic, but our work was mostly dedicated to the fact that we wanted to generate the best way in which the cells into the Ferrari car can safely arrive into the operatory room. So we've done this study where we took the cells, you see the bioreactors I just showed you. The cells were transported into different buffer, like in normal syringe, like the one we are using in the clinical practice. And these cells were then evaluated for their potential, their viability after a transportation of 18 hours, an adhesion to the granules, and then the capability to make bone, because we wanted to mimic the same condition that are happening into the clinical setting. Very briefly, the cells are adhering to the granules. You see they are covering totally the granules. And if you use, curiously, if you use normal saline, the cells are actually very fine into the syringe. So rather than having a drug, we are having a cells into a normal saline suspension, which is capable to colonize the scaffold and generate the bone. And we proved that again to a mouse model where these cells are actually coming from the shipped MSCs, which are generating human collagen 1A2, which is the most known constituent of human bone. So what's going on at the moment? We have essentially 4 clinical trials. 2 of them are, one is completed as indication for cleft palate in the children's setting. The one which is open starting July this year is for non-union defect, and the third one, which just been approved by the regulatory body in Europe, is for osteonecrosis, where we're actually targeting the osteonecrotic tissue, very similar to the heart degeneration in here. So we are pushing into the clinical setting. So this was just one example I wanted to give you. The other part, I'm ending my presentation here, because we can actually, I wanted to introduce the concept that we can actually use the MSCs and moving from a regenerative medicine to the setting of cancer destruction. So why cancer, and why I'm talking about that? Because cancer also contains a lot of stroma, a lot of stromal cells, like the mesenchymal stromal cells that I was just mentioning. So these stromal cells are actually supporting the growth of tumor. But where these cells are coming from, these are stromal cells into the tumor. There's a lot of reports saying that these cells are actually coming from the bone marrow and from the adipose tissue, and they're very similar to the adipose mesenchymal stromal cells. So the idea we had is, can we use these MSCs that we know very well to amplify in vitro to target the tumor? So our vision of MSCs in the oncology is that we can actually use these MSCs to target the tumor because we can modify these cells to produce anti-cancer molecule, enabling their production for specific application. And this is just a modification of the slides that I just showed you. So we have cells here. Rather than use their naive potential to produce molecules, we can actually modify the cells, including gene, and using genes that are able to have an anti-cancer effect. In this case, we are using a gene encoding for a protein called TRAIL. TRAIL is an anti-tumor agent, which was well known in the clinic, but was poorly utilized because of a poor pharmacodynamic effect. So our strategy now is we take the cells, we amplify, we generate, we insert the TRAIL gene inside, and we then transplant them back into the patient. Very similar to the bone strategy, but in this case, this is an oncological patient, and in this case, we gene modify the cells to enhance the production of an anti-cancer agent capable to defeat cancer. This is just in vitro data. These are stem cells producing TRAIL in combination with tumor cells. Just see the row, the last row here. You see the difference between these figures and this figure. You realize that these cells, this debris of cells are actually not present here and not present here. These debris are tumor cells that are dying. We can quantify these dead cells measuring their propedium iodine percentage. And if you measure these dead cells, you see that after 24 hours or 48 hours, we can get up to 90% of dying cells with this approach. We challenge this study testing pancreatic cancer and colon cancer, having the same result. We then move into the in vivo study where tumors were implanted into non-skid mice and cells were transplanted. The impact of this study is seen here. You see a tumor which is untreated and a tumor which is treated. There is a dramatic reduction of tumor growth. We are now amplifying this approach, targeting sarcomas and targeting other cancer like myeloma in collaboration or alone. And I want to end up this presentation showing some data which are not published. So this is an histology of a sarcoma implanted into mice. These are blooming cancer, so a lot of cells. But if you use stem cells encoding for an anti-cancer molecule, you see that these cells, which are staining here in red, are getting into the cancer. They are destroying the tumor, and they are shrinking the tumor size. So I'm ending here. Thank you very much for allowing me to speak about our results. And I want to follow up the caution message that was sent by Professor Ferrari. We cannot start to do a stem cell here or stem cell there. We need to really understand what we are transplanting. We need to generate a strong biological rationale before doing any type of clinical application. So I'm thanking the whole group in Modena and the collaborators in Reborn. I'm also have the pleasure to invite you to our stem cell meeting in Paris. That will be in April if someone is interested. We have also a cardiovascular and lung disease regeneration session which has been implemented. And I thank you very much for the attention.
Thank you, Massimo, for the very well presentation. Discussion is open. Any question for Massimo? I have a curiosity for you.
Yeah.
I see in one of your slides that in China there is 140 clinical trials ongoing, more than in the US, more than in Europe.
Yeah.
What do you suggest this from political point of view?
Well, you know, China has been going through a tremendous development, which was also linked with some dark side issues. And one of the issue has been faced by the Chinese government. So they have recently implemented a new law, which is absorbing the FDA. The SFDA, which is the Chinese FDA, starting from April 1st, implemented a new regulation because they also realized that in some cases the patients were treated by, for any type of disease. I was myself in China, and I met persons which were treated by MSCs intravenously, not because of a specific diseases, but just because they were aging. Okay, so this is really something which is, which is pointing out again, we cannot use a Chinese traditional medicine approach on high technology cells like MSCs, because we are actually infusing living cells. So we need to be sure that these cells are actually doing what we want and not what, the traditional Chinese medicine. I'm not certainly against Chinese medicine, but translating this concept may be kind of dangerous.
Okay, thank you. There is a question, Professor Fabri.
Massimo, if you had to bet, where do you see the most likely positive application of the stem cells in chronic condition?
Well, I think, for skeletal disorders, I think is already ongoing. I mean, there are phase 3 studies ongoing. There are companies which are investing a lot of money in that. I think osteoarthritis and bone is one of them. Then I think the second one, which is coming up very strongly, is the let's say inflammatory disorders. Not because what these cells are capable to become, but because they produce a lot of anti-inflammatory agent. Like they are used for Crohn's diseases in phase 2 studies. They are used in some also in some lung disorders where fibrosis and inflammation might.
Yeah, the issue is that one common feature of all chronic disorders, and I happened to attend a very interesting lecture on liver fibrosis that actually was taken as a model. You take all these, chronic heart failure, liver fibrosis, lung fibrosis, and so on. You have the scar. And this scar is, as far as we know, irreversible to anything we do. So the issue is any chance that by injecting these stem cells or by stimulating themselves or by trying to reverse this, because as far as we know, really there is nothing available so far.
Yeah, the issue of let's say a dying tissue which is generating the scar, it's unfortunately very common to all these disorders. But there are lots of so these cells have been proven to produce a lot of anti-inflammatory agent, but also lots of decoy receptor for instance for TGF-beta. Okay, so they can actually try to reverse this fibrotic event that is maintained by FGF or TGF-beta. They produce a lot of decoy, and this decoy is subtracting from the environment this fibrogenic milieu. At the same time, they are capable to support the survival and reproduction of endogenous cells. This is the hypothesis, okay? But there are lots of data which are supporting that. These cells are becoming more like a a drug-producing agent rather than cells which is making the brick into the damaged walls. But it's growing tremendously. It's growing tremendously. Also the knowledge that we have about this aspect.
There is another question, please.
You mentioned two potential sources of stem cells in the clinical practice. One was the fat tissue, and you didn't discuss so much about that. Can you comment a bit more on that? It's so easy and applicable in clinical practice that it should be taken in serious account, I guess.
Yes, absolutely. No, I don't want to get into much details, but we have been working on that since quite a while. So adipose tissue, it's a great source of adult progenitor cells, and actually their proliferation potential of these cells, if you compare them with the bone marrow, is higher. Okay, so they grow better. The source is certainly more available, and we just need to be careful that you know, the plastic surgeons, which are actually giving you the fat, you know, they are working mostly in the springtime before the bikini, the summertime, okay? Because people want to get slim before the summer. So the harvest time for fat is just very limited in the time. It's really something that, you know, you have to consider. But you can amplify the cells for a long time. You can bank them. They can make lot of, one of the most intriguing aspects that they do they produce a lot of VEGF. So vascular endothelial growth factors and a lot of you know, pro-angiogenic factors. These are actually the cells which has been called, has been defined more similar to the perivascular sites, to the pericytic cells. And since they are in nature supporting the endothelial cells, there is a lot of hypotheses and some research which is supporting that these cells might be very useful for, they are used for critical limb ischemia, for instance, already. They inject these cells into muscle, and they see that there is an increase of angiogenesis. They also have been used for the cardiac regeneration. So many applications, as much as bone marrow, and even greater, I would say.
Okay. We hope that in the near future the same success obtained in the orthopedic field will be available also in chronic pulmonary and cardiac field. Okay.